All right. Good afternoon, everyone. Thank you for joining us for the 2024 Family Council's Ontario November Summit. My name is Taeyang Zhang. I am the event and project manager at FCO. We hold this summit in the fall to bring innovative topics to family councils and discuss newly published research or resources. Today's summit will begin with a presentation from Lisa Campbell from Osteoporosis on bone health, followed by a discussion session from Family Councils Ontario, led by our own Kathleen Edwards, about a newly launched transition guide into long-term care. Before we start, I would like to take a moment to recognize the land on which we are gathered today. We're meeting on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. We wanted to share a few logistics and housekeeping rules before we continue with the summit. You'll notice that all participants are in listen-only mode. So we have reserved time at the end of Lisa's presentation for an interactive question and answer period. And we will be using the questions submitted in the Q&A box to moderate the Q&A session. So I invite you to submit your questions in the Q&A box throughout the presentation, and we will get to it at the end. If you are experiencing any sort of technical issues or any questions about logistics, you can write to me in the chat and I will get to them. And also, for your information, today's session on bone health will be recorded, is currently being recorded, and it will be made available on our YouTube channel next week. We will not be recording the discussion session that we're doing afterwards. So now it's my pleasure to introduce you to our guest speaker, Lisa Campbell. So Lisa Campbell is a regional integration lead with the Ontario Osteoporosis Strategy for Osteoporosis Canada, covering Hamilton, Niagara, Halton, Brent, and Haldimand, Norfolk areas. Lisa is the RIL liaison between the long-term care strategy and the OOS team. Lisa was hired when the Ontario strategy was first funded in 2005, 19 years ago. Lisa has been working in the social service sector for more than 39 years. She graduated as a social service worker in 1985 and has continued studies in psychology and human resources. Other than bone health and fracture reduction, Lisa also has interests in addiction and mental health, and outside of work, listening to books while walking on the waterfront trail and cooking. She has recently moved to Grimsby in the Niagara region and is looking forward to getting involved in the community. So following Lisa's presentation, Sam Peck will moderate the Q&A period. Sam is the Executive Director of Family Councils Ontario. She holds an honors BA from York University. A dedicated lifelong learner, she also holds advanced client-directed case management and volunteer management postgraduate certificates from Humber College, project management certificate from the University of Toronto, a master's certificate in adult training and development from the Schulich Executive Education Center, and is currently working on a voluntary sector management certificate from Toronto Metropolitan University. So Sam will be joining after Lisa's presentation for the Q&A. So now it is my pleasure to pass the floor to Lisa.
Thank you very much. It's great to be here today. And I am sitting right here in Grimsby, and it's quite an overcast day, but it's not snowing, and I'm grateful for that. So I'm going to share my screen, and Taeyang, you can just confirm with me that everybody can see it, maybe with a thumbs up or something.
Perfect. We can see it.
Excellent. Okay. I'm just going to try and move that out of the way. Great. Thank you very much. So today we're going to talk about bone health and fracture prevention. I can't. Oh, there we go. So who we are, Osteoporosis Canada. We're here to educate, empower, and support individuals and communities in the risk reduction and treatment of osteoporosis and osteoporotic fractures. All of our information that we present or that we have offered on our website, it's all done through medical and scientific issues with our Scientific Advisory Council. And this council is made up of volunteer clinicians, researchers, and educators who are experts in the field of osteoporosis and bone metabolism. We receive our funding from the Ministry of Health, and this enables the Ontario Osteoporosis Strategy to prioritize fracture prevention for people at risk of hip and other osteoporotic fractures. And you can see by the logos on the bottom of my slide, these are all these key stakeholders that are involved in this strategy. Unfortunately, Ontario is the only province that has a strategy that's dedicated to osteoporosis. So we're lucky in Ontario, but not the rest of the country. So what do? We focus on fracture prevention, so reducing the risk of hip and other osteoporotic fractures. We also have health professional education and outreach, increasing evidence to inform practice by healthcare professionals, and patient education and self-management, increasing the capacity of at-risk patients to understand and manage their fracture risk. As you know, if you're seeing your healthcare provider, you only actually see them for a very short period of time. So it's important that we're able to self-manage our own healthcare. So a little bit of bone health background. Change is constant with our bones. We know that we start losing bone at a rate of about 1% per year when we're in our 30s. So we have activities of what's called osteoclasts and osteoblasts that's varies throughout our life cycle. And we actually reach our peak bone mass until we get to be about the age of 20. So in fact, that's quite young. We know that at 20, our bones are at their peak. And then we start to lose that bone density at a rate of about 1% when we reach our 30s, and then other factors contribute. We know at menopause, bone loss then increases to 2 to 3% per year. And in men, bone loss is slower, but once men reach about the age of 65, they finally catch up to women. And we sometimes it's said that osteoporosis is actually a pediatric disease, but it doesn't show up until we're at an older age. So some factors that influence our bone health. We want to take a look at how we can maintain and protect our bones. It's important to point out that not all factors are modifiable. For example, genetics really play a strong role in the development of osteoporosis. We know by one of our scientific advisories who is in Nova Scotia, she has said that about 70% of osteoporosis is actually genetically linked. So we can't choose the family that we're born into, but you can make some choices regarding lifestyle that really can influence and reduce your risk of developing osteoporosis. Some non-modifiable are, say, mothers and daughters and twins. We maintain our bone health through monitoring and improving other factors which are modifiable. So genetics really is just the one that's not modifiable, and hormones. Other ones we can get some help with. So when we look at primary and secondary osteoporosis, primary osteoporosis is when bone loss is associated with menopause, age, or unknown causes. These are the things that people talk about, sort of a normal part of aging. We try and get away from saying that, but typically there are people that are just going to have osteoporosis and it's not related to anything else. Then we have secondary osteoporosis. This one is specifically associated with or secondary to a disease or drug therapy. So, for example, some drugs that may influence our bone health would be glucocorticoid steroids, um, aromatase inhibitors, anticonvulsants, some cancer chemotherapies. Um, those can really affect our bone health, and therefore, say we could have some of those medications that we're on and then develop osteoporosis as a result of it. Some gastrointestinal and nutritional disorders like irritable bowel syndrome or celiac disease, eating disorders, perhaps people who have had gastric bypass, anything that really affects the absorption of our foods that could then impact our bones. Rheumatoid arthritis is also one. Another disorders, multiple myelomas, Parkinson's, those are diseases that impact your bones. So, some disease and fractures in women, if you take a look at this, you can see that people, the rate, sorry, of osteoporotic fractures is much higher than heart attack, stroke, and breast cancer combined. And we don't hear about that often. And if you look at the type of fractures, we know that there are significant numbers of hip fractures or vertebral fractures. And perhaps some of you have heard about that either with your friends or family members who are actually living in long-term care homes right now. But we know that people don't hear about it in the same way you hear about heart attack and stroke and breast cancer. So let's talk about fracture prevention. Through the Ontario Osteoporosis Strategy, we have what's called a fracture screening and prevention program. And perhaps some of you have experienced this. We're in 36 fracture clinics across the province. So we have a fracture prevention coordinator who identifies, assesses, and manages osteoporosis and fracture risk in fragility fracture patients, ultimately reducing refractures, improving patient outcomes. So ideally, this fracture prevention coordinator or nurse will meet with you after you've had a fracture and we'll talk to you if you're over 50, sorry, and we'll talk to you about how did you break the bone and look at ways that we can make sure that you get linked up with proper specialists and make sure that your bone health is treated, not just the fracture, because oftentimes the fracture gets repaired, perhaps you have to have surgery, but then that's it. We want to make sure that bone health is treated as well. So these fragility fractures that I mentioned are broken bones that happen spontaneously or as a result of a normal daily activities or fall from a standing height or less. So for example, if you are 80 years old and you're downhill skiing and you fracture your leg, that's not the type of fracture that we're going to talk to you about in terms of bone health. If you're 80 and you're downhill skiing and you break a bone, well, I'm happy for you that you were brave enough to go out and ski, but those are not what we call fragility fractures. Fragility fracture might be if you're out walking the dog and you trip over seemingly nothing, and you fall and you break a bone, that's what we call a fragility fracture. Sometimes people have said they heard their hip fracture before they even fell. So they heard it pop. And these are for very severe cases of osteoporosis, but it does happen. Fragility fractures are the most serious sign of osteoporosis. And we know that simply by having a fracture like this should trigger a bone mineral density test so that we can intervene at that point, because we also know that other fractures are coming down the road. So for example, if you have a wrist fracture, we're pretty confident to say if you don't do anything about it, then ultimately you could have a hip fracture down the road. It's like a warning sign. So height loss is another early warning sign. And I think it's a pretty standard thing that we talk about height loss as a normal part of aging. And there might be some normal height loss. In terms of our bone health, we're looking at people who have lost, say, 3/4 of an inch in 1 year or 2 centimeters, or perhaps you've lost 2.5 inches since you were in your 20s. So, for example, with myself, when I was in my 20s, I used to be 5'8", and now I'm only 5'6". So that is certainly a warning sign that I took into consideration when I asked for some further investigation. So you want to take a look at that. You also want to look at if you've got a more rounded spine. So if you look in this picture, the first picture where the skeleton is standing upright, that indicates 55-year-old. And you see then at 65, there's a little bit more of a rounding curve, or what we call kyphosis. And then the person who's at 75 has got quite a severe rounding or kyphosis, and their abdomen is also protruding. So you don't lose height in the same way that you lose weight, for example. But what happens is your spine starts to curve, and therefore it's called losing height. When you have some of that protuberant abdomen, that can also impact your lung function. You could have some sleep disturbances as a result, and it can be quite painful. If you've ever seen anybody that's got that curved spine, it can be quite quite uncomfortable and quite painful if there's a sign of vertebral fractures. So the impact of some of these fractures, we know that fragility fractures are responsible for excess mortality, morbidity, chronic pain, admission to institutions, and economic costs. We know that people with a hip or vertebral fractures have a substantially increased risk of death after their fracture. Multiple vertebral or spinal fractures can cause significant pain, anxiety, depression, again, like I said, a reduced pulmonary function and agitation. These are really some of the things that I mean, lots of these things we don't want to have to experience or go through. And perhaps some of your family members are going through this right now. With a hip fracture, it's usually pretty obvious if someone has a hip fracture and it's treated right away. Vertebral fractures are not always treated that quickly. I mean, many of us have had back pain in our lives at some point, but it's never investigated for a vertebral fracture. So this is what we want to make sure that people get this looked after. So some hip fracture stats. We know that at least 1 in 3 women and 1 in 5 men will suffer one of these fragility fractures in their life. The risk of a subsequent fracture in this population increases to 9.5% fold. So we know, as I said, that often it's a warning sign that another fracture is imminent if you don't have treatment. The risk of experiencing another vertebral fracture in the year following the first vertebral fracture is about 20%, which is quite high. And the risk of experiencing another fracture in the year following your hip fracture is at 5%. So if you are, we know that about 25% of people, the mortality rate is higher. So somebody could potentially die within the first year following a hip fracture. And those are pretty alarming when you think about it. About 50% of those people may end up in a long-term care home, or those people who go back to their own home and regain their activities of daily living that they were doing before the hip fracture. We know that these people may end up fracturing the other hip. So you get through the first one, and if you have to go through a second one, that that absolutely will increase that mortality. So if we look at a hip fracture, the loss of function and independence among survivors, just this quick infographic, We know that 40% are unable to walk independently again, which means you may need a mobility aid like a walker or a cane. 60% still require assistance a year after fracturing their hip. As I said before, 20 to 24% may die within the first year after a hip fracture. It may not be, people may not think that it's that actual hip fracture or osteoporosis that was the cause of death, but often some of the issues that happen may lead to mortality. 50% of people with one osteoporotic fracture will definitely have another one, and 33% become dependent in a nursing home within that following year. And I'm not sure that that's something that we strive to do. If we do end up in long-term care, then there's ways that we can still have a good quality of life, but I'm not sure that anybody has that as an aspiration or goal that they're looking forward to. Excuse me for a minute. So hip fractures in women, we know that osteoporosis is a major public health problem and represents a steadily increasing cost to our system. The most substantial cost of osteoporosis to the healthcare system really is directly as a result of the treatment. In 2010, this cost was estimated to be about $2.3 billion. And that estimate includes acute care, outpatient therapy, and indirect costs. We know that, as I said, 10% will refracture within a year, 53% died or developed new total dependence within 180 days, and function declined substantially after that fracture. About 18% enter long-term care, and that mortality rate, again, 20% of individuals returning to the community, they may die within that first year, and 40% who are in long-term care. So fracture, we know that by the year 2041, the cost of a hip fracture, or the cost of hip fractures in our healthcare system, is estimated to be about $2.4 billion annually. And so there's, we're looking at this loss of independence due to a hip fracture. It could really, be quite detrimental. So fracture management. So in 2023, we updated our clinical practice guidelines for osteoporosis. And I'll just quickly go through some of the changes. We really took a close look at exercise, nutrition, fracture risk assessment, treatment initiation, pharmacological interventions, duration and sequence of therapy, and monitoring of osteoporosis or bone health. So when we look at the 2023 guidelines, so specifically about our bone mineral density testing, bone mineral density is the only test, the only diagnostic that we recommend to diagnose osteoporosis. And hopefully, although I can't see you, I'm hoping that if anybody here is over the age of 65, that at least you're looking at having a bone mineral density without waiting to break a bone. So in the year 2010, we had a little bit different, and I'm not going to go over the way that we did do it just for the sake of time. But for now, 2023, we suggest bone mineral density testing in postmenopausal females and males who are age 50 to 64. If you've had a previous osteoporosis related fracture, or if you've got more than 2 of these clinical risk factors, which I'll talk about. And if you're over the age of 65, if you've had 1 clinical risk factor, or just period, anybody who's 70 years of age or older should have one of these bone densities. The other thing in our 2023 guidelines, we started recommending that people follow Canada's food guide to make sure that they get enough vitamin K or magnesium. We don't suggest that people have to supplement vitamin K or magnesium, but we didn't mention it at all in 2010. but now we're talking about it to make sure that people get this through through their diet. Perhaps a physician may recommend that you supplement, but in general population, we're saying that it's not necessary to supplement. So the World Health Organization has diagnosed osteoporosis as a skeletal disorder characterized by compromised bone strength, predisposing a person to an increased risk of fracture. So if you look at these pictures, the normal bone looks quite a bit stronger. It's not as porous as the osteoporosis bones. You can see it's not quite solid, but it certainly does look a lot stronger. And as I said, a fragility fracture is the most serious manifestation of osteoporosis. Sometimes you can have, with severe osteoporosis, you can have fractures and you may not even know about it. I think typically people think of a fracture or a broken bone is something that definitely is going to require surgery or casting or some kind of attention. But in fact, osteoporosis is called a silent thief because sometimes there's no symptoms associated at all. You may have these fractures, but you may not feel them. So that's very dangerous as well. That's why it's important that after those ages, you have the bone density so that you can find out. So exercise and resistance training. One thing I want to point out is important to differentiate between osteoporosis and osteoarthritis. Osteoporosis is a disease of the bone, yet osteoarthritis is a disease of joints and those surrounding tissues. An accurate diagnosis is important for pain management and treatment and management of the disease. There is no pain with osteoporosis unless you break a bone. So I think that's people often get the two confused. But so when people have said to me, "Oh yeah, I have pain in my knees and pain in my hips," that's more likely to be osteoarthritis and therefore needing treatment. But with osteoporosis, it doesn't hurt unless you break that bone, and then when you do, look out because that really does hurt. Those big ones were the hips and shoulders, those kinds of fractures. So in 2023, we're suggesting progressive resistance training. So walking is a great activity. It's good for enjoyment or other benefits, as it says here, but we really want to make sure that people are having progressive resistance training. In 2010, we used to say just do resistance. Now we want people to be progressive with that. So we want to make sure that if you start out with a very lightweight, maybe even a water bottle or a can of soup, that you look at increasing that and making it a little bit heavier. I don't expect that anybody's out joining a gym and doing major weightlifting, but we do want people to do some resistance training at least twice a week. That includes exercises targeting abdominal and back, extensor muscles like planks or that kind of thing, which sounds really impossible, I'm sure, but you have to start somewhere. So start low and work your way up. As I said, we recommend balance and muscle strengthening exercises greater than twice a week. We want to make sure that people are eating foods that are rich in calcium and protein. In the 2010 guidelines, we didn't talk about protein. We did tell people that to get calcium and vitamin D, but we didn't talk about protein. If you follow Canada's food guide and get the protein that's recommended there, that is exactly what we're talking about. We've also changed our vitamin D supplements. We used to say for vitamin D, people need to get 1,000 to 2,000 international units a day. And now we're changing that people supplement only 400 international units. So that's a significant drop. And again, I'll qualify that by saying this is only for osteoporosis. Your doctor may suggest that you need to be on a higher dose, and that's perfectly fine. But in terms of bone health, all you need is a supplement of 400 international units. The calcium recommendations is the same, 1200 milligrams, but we want to make sure that people are trying to get these sort of calcium, protein, vitamin K, that you're getting that through your diet, not supplementing. So again, with exercise, we recommend balance and muscle strengthening. Keep those, your resistance training, start adding weight on a regular basis. And for people to get about 150 minutes of activity per week. When you say it like that, it just sounds so much. It sounds so long, but it's really not. That would be like a half an hour walk 5 days a week, which is really easy to obtain. And you can do that in shorter periods, but it's not just the walking. It's really important that people do get that resistance training. Balance training is also very important with osteoporosis. We want exercise that improve balance and coordination because this will help reduce falls and fractures. Perform exercises to challenge your balance daily. Maybe you can find a class in your community that includes balance exercises, or get help selecting the right exercises for you from your maybe a physiotherapist you're seeing after you've had a fracture. But you can make balance exercises a part of your day. So, for example, you can just do simple heel raises while you're waiting for the kettle to boil. Or every time you go to the bathroom, stand up and do a few balance exercises. You can see from the picture, the woman there that's just raising her legs, starting out holding on to the chair, and then maybe working up to doing it without something to hold on to, because you want to increase the difficulty and intensity of your balance exercises over time. So the goal of exercise in osteoporosis, of course, is to improve your overall health, but you want to improve your posture, to keep that spine straight, to avoid or some of that curvage that we talked about earlier. You want to decrease your risk of falls, definitely, and minimize future fractures. If anybody has ever had a fracture, you know that it absolutely can be excruciating and really hard to bounce back from. Some of the exercises, resources that are available, we have through Osteoporosis Canada, we have a program called Too Fit to Fracture. And this is an exercise page that gives you exactly the types of exercises you should be doing. All the stuff that's available on our website. We also have a program called Bone Fit, and this is specifically a program that teaches fitness providers or physiotherapists, occupational therapists, exactly what types of exercises they need to be focusing on when working with seniors. So if you're deciding, if you do have osteoporosis and you're deciding to join an exercise group, make sure that the person who's leading knows that you specifically have osteoporosis or low bone density, so that they know exactly what you should and what you shouldn't be doing. So some precautions we want to make sure we pay attention to if you have osteoporosis. You want to avoid movements that involve rapid, repetitive, weighted or end reach forward bending or twisting of your spine, especially if you've had some of those spinal fractures. Twisting of your spine, that's an activity that's pretty typical in golf, for example. If you are newly diagnosed with osteoporosis, maybe it's not the time to start golfing. But if you've been golfing for years, you just want to make sure that you do a stepped turn instead of twisting your body. You want to avoid lifting from or lowering to the floor. So, for example, if you're bending down to pick something up from the floor, you don't want to bend at the waist. You want to make sure that you bend your knees. And you want to make sure that your movements are slow and controlled, not to push to your to the limit of your range of motion, but just be very aware. And hold, if you are picking up a weight or a box of say, even a grocery bag, hold that close to your body, not up over your head. Not that you'd pick your groceries up over your head, but if you're lifting weights, for example, don't start swinging them up around over your head. Keep them close and tight to your body. And you should really have a consult with a physiotherapist or an occupational therapist if you know you have osteoporosis and you've already had a fracture. So fractures and falls really go hand in hand. It's important to recognize. Oh, it looks like my slide is cut off on the ends. It's important that osteoporosis, fracture prevention, and fall prevention are recognized as a trio of interrelated health issues. And an intervention targeting one of these three health issues should really acknowledge the other two. So, for example, if if you didn't have osteoporosis, for example, if you had good, strong, healthy bones, falling wouldn't be an issue because you wouldn't likely break your bones. If you think about children, for example, and the number of times they fall, their bones aren't breaking every time they fall. But if I were to fall like that, for sure my bones would break. And that's why we want to make sure that whenever you're thinking about bone health, disease, or osteoporosis, that you make sure that you consider falls and fractures. We know 1 in 2 adults over the age of 80 will fall every year. 95% of hip fractures in people who are over 65, that's as a direct result of a fall. 1 in 3 adults over the age of 65 will fall. And if you've fallen once, you have a greater chance of falling again. And some of the consequences of a fall, as I've already mentioned, mortality. It can be a large financial burden on the health system, more morbidity. You can also have some soft tissue injuries, not just fractures. Perhaps there would be a head trauma and you end up with a brain injury. Could happen. And loss of confidence is a big issue for people who fall. Once you fall once, you then have a fear always that it's going to happen again. So what if we do fall? We're not, we're just not going to dust yourself off and think that everything is okay. We want to make sure that we take a look at that fall. I think, in my experience, we find people are afraid to mention that they have fallen for fear of what might happen, um, to their family members. I know my mother uh, never quite tells me the full story when she's had an issue. And, I think that we need to talk about it openly. We have to make sure that we go and have further assessment done so we can make sure that if you did fall and you didn't break a bone, let's take a look at that and get an intervention at that point. And be cautious, be aware of risky situations. Problems arise when normal caution becomes the fear of falling. And then, the more you fear, the more likely it is that you're going to fall. Some things that you may want to look at in terms of fall prevention in order to make sure that you stay independent, have your vision and your hearing checked regularly. Surprising hearing also affects falls. Have your medications reviewed regularly, have your blood pressure checked so we can, one of the symptoms of a blood pressure that's out of whack is dizziness. So we want to take care of that. Take better care of our feet and review the footwear that we have. The number of people that I see going around with flip-flops on, or 80 years old flip-flops, or shoes that are really inappropriate. I wear running shoes every day, all the time, and I've gotten beyond that, or I'm concerned about wearing pretty sandals and that kind of stuff. Participate in a regular exercise program, which should include those balance exercises. Eat a well-balanced diet, stay hydrated, and review your calcium and vitamin D, and review your home for safety hazards, such as those pretty little scatter mats, or make sure that you have night lights so that makes your area safe, sorry. And learn some more about some equipment that you might need in your home. Perhaps a walker, for at night when you're up in the middle of the night and you need to go to the bathroom, you might be a little more unsteady. And there's lots of other recommendations, but we won't get into that now. So nutrition. Oh, excuse me. So recommendations on exercise and nutrition for fall and fracture prevention in postmenopausal females and men 50 and older. The recommended vitamin D, as I said, if you're under 70, we're saying 600 international units of vitamin D total. So the supplements that you get for vitamin D, I think the lowest you can get is 400 international units. So we recommend that you take that 400 international unit supplement and then get the other 200 from your diet if you're under 70. If you're over 70, you can take 800 international units of vitamin D a day. And as I said before, we used to say quite a bit more. And calcium, are we getting enough calcium? So 51 to 70 years old, we recommend 1,000 milligrams of calcium a day. And if you're over 70, 1,200 milligrams a day. Now, we're talking about elemental calcium, and we're also suggesting that people get the calcium through their diet. So Osteoporosis Canada, we used to just have a calcium calculator. Now we have a nutritional calculator where you can go on the website, enter the amount of calcium that you're eating or what you've eaten during the day, and it'll tell you whether or not you need to have more calcium. And maybe that will then just give you the okay to go ahead and have that bowl of ice cream in the evening because ice cream has calcium. We strongly recommend calcium from food, but if you do have to supplement, do not take more than 500 milligrams at one time. Space those supplements throughout the day because you can only absorb 500 milligrams at one time. So it wouldn't benefit you to take a calcium supplement with a cup of milk, for example. You can only get 500 milligrams a day, and anything beyond that, you're just going to pass it through your urine. We recommend 0.8 over 50 that you have 0.8 grams of protein per kilogram of body weight a day. So if you just go follow Canada's food guide, which I'm sure most people have heard of, that'll give you the accurate amounts that you need. And some protein-rich foods in that food guide are beef, pork, chicken, fish and eggs, milk products. But if you're a vegetarian or vegan, or for religious purposes, certainly legumes, beans, nuts, and seeds may be a great way to get some protein. So the goals of medication for osteoporosis is really to reduce any fracture risk, prevent further bone loss, and increase your bone mass. Typically, medication for osteoporosis, you may have your bone mineral density, go on some osteoporosis treatment, and then when you have a follow-up bone density done, it'll show that there's been no change. And that's what we call a successful treatment. It may not, your bone density may not change at all, but as long as it doesn't get any worse, that's the main thing. And how will you know if it's working? You won't feel any different. But as I just said, you'll know if your bone density remains the same. It's only monitored through bone density tests. Discontinuing medications that you've been put on by your healthcare provider may result in bone loss and rather quickly. So if for some reason you're on osteoporosis medication and you're thinking of discontinuing them, I would strongly encourage you to speak to your doctor about it. So some other partnerships through on our website, we have an awesome document called Your Fracture Journey that you can go to our website and get this. It's a self-management tool that helps you to manage where you are, to write things down, helps you, as you see on the list. It tells you different exercises, what nutrition, different prescription, medication information, how to reduce your risk of falls and fractures, and how to manage the pain of a broken bone. And this is all in this fracture journey that's on our website. There are some education videos that you might be very interested in. These videos are done specifically to our osteoporosis long-term care folks. And the website is there. It's at jerriscenter.ca. And you can take a look. They've got all kinds of specific videos for personal support workers, physiotherapists, and assistants, some of the exercise trainers and exercise professionals, and restorative care. These are very short videos, so I would encourage you all to have a look at them and what you can do. The slide on the bottom there shows a woman named Devora, and she's a patient who lives in or a resident who lives in long-term care and has osteoporosis, and she talks about her experience. We also have the Canadian Osteoporosis Patient Network, and this is made up of people who have osteoporosis, and they make sure that that information is out to people through our, it's like a newsletter that's sent out by email when I think it's done quarterly now. Some other residents and family members for long-term care. You can see some of these handouts that are through the Jerris Center. This is something that you might be interested in, talking about fracture risk factors specifically for long-term care residents. And I know you're with the family council, so you perhaps have some family members that are in long-term care, and these talk about some of those things. One of the things I know that I was asked to talk about today was hip protectors. Hip protectors are great these are for residents who are mobile and who are at a high risk for fractures. So if they wear a hip protector, that can help them just give a little extra padding. They used to be quite bulky, and they've really slimmed down. You can get them it's almost like a gel pad that just covers your hips. So if you do fall, that little hip padding or that gel pad will help. For residents who are not high risk for fractures but are mobile, hip protectors are also recommended depending on resources that are available to the resident. I know that they can be quite costly, but they are very helpful. If if your family member who's in long-term care would be open to wearing those. The other costly thing with hip protectors is obviously you need to have more than one pair. They're like underwear or briefs. So there's something that you have to change regularly, and they are shown to be quite successful in protecting hips. Now I can take some time to take some questions if you have any, and I will stop sharing my screen.
All right, thanks so much, Lisa, for this really informative presentation. So a few questions. So the first is are there resources on the website that home staff or council leaders could use to share with families and perhaps residents as well about bone health, osteoporosis, fracture prevention, and ways to address the issues?
Absolutely. There are lots of resources, but I can offer, we have, as I mentioned, we're across the province of Ontario. There are 9 people that are doing the same job as I am, and part of our mandate is to go into long-term care homes and provide presentations to the staff. There's some great research that's being offered now where people will go into the home and teach staff on how to work with people who have osteoporosis. There's right down to transfers with patients. It's also, we know that sometimes people can't articulate where their pain is or why they're in pain. And we know that a lot of times that could be vertebral fractures, but yet people can't articulate. We're happy to work with any home, anywhere in the province.
Wonderful.
So you can certainly pass my name and my contact information.
Wonderful. Regarding people not being able to explain where their pain is,
Mhm.
what recommendations do you have for families to be able to, so caregivers or home staff about um, people supporting people with dementia who may
Mhm.
not be able to explain what hurts or what has led to an injury. What
Right.
strategies has the team found effective?
I think the important thing, one, as I said, if people can't articulate, I think we need to just listen and maybe not listen to words that we're saying. We can watch through body language and hear patients that way. One of the things that we really want to find out about a resident when they're coming into a long-term care home, there's detailed assessments that should be done in terms of their bone health. So if we know that mom had osteoporosis, was diagnosed at 70 prior to dementia, we know that it's a
Mm.
possibility. If people have had a bone mineral density, that can highlight it's something that we need to watch for. We also know, about 80% of people who are living in long-term care have osteoporosis.
Hmm.
So if someone's crying out in pain, it's almost, I hate to say we can just assume that that's what the issue is, but it may be. And I think just taking the time, which I know is something that people often complain about, not having time or not being listened to. Yeah,
Yes.
yeah.
Another great question. Is there any evidence that hormone therapy during or post menopause can help mitigate osteoporosis in women?
There was a time when hormone replacement therapy was recommended as a treatment for osteoporosis, but we don't recommend that anymore. I think that there are very clear guidelines about um, hormone replacement therapy for just that, for if you have hormonal issues, that, but not for osteoporosis treatment. But it used to be there, um, there was a medication specifically, it was called calcitonin, and it was something that was used. We don't recommend that anymore. It's not, it's just not one of the recommendations.
Hmm. Okay. Um, Are there, so when you talked about calcium and vitamin D and other vitamins, how are those, uh, done in long-term care? I'm
Mhm.
assuming it's got to be approved or prescribed by a medical professional, and there's processes to go through. So how does that work?
Well, in a it would be nice to think that the food services program are making sure that they're providing these calcium enriched diet and or making sure that things are high in protein and making sure that residents get that, which we know is a challenge. That's, by us recommending Canada's food guide, that's pretty standard
Hmm.
thing that the food supervisor, the food service supervisor should be incorporating that, making it available to residents. Now, the other side is whether or not people are actually going to eat, whether they're going to eat it. So I think perhaps as a family member, that's something that you can look at and try and determine how much, say if, how can you tell if your family member is getting enough of that? And if they're not, then maybe speak to the physician about
Mhm.
supplementing,
Yeah.
right?
Okay.
Because it all depends on how much people are taking in. And
Hmm.
make sure that there's ice cream available at
Hmm.
every meal or other things that we've put off and not eaten for so long, because it's so bad for us. But, I think that provide things that people like to eat. And I know that that's hard. It's easy for me to say to do that. And I know that from my experience with long-term care, that food is always a big issue.
Hmm.
It's such an integral part of a person's well-being, but it's also one that is often complained about. People are not happy with food that's offered.
Ice cream tends to be hyper palatable and enjoyable, and the
Yeah.
added source of protein and vitamins
Right.
is a way to go.
Right. And offering, and I know it's hard to be able to offer the variety
Mhm.
it can be challenging, but then, I don't know how flexible homes are to have the residents, family members bring in stuff, some
Mhm.
little extra stuff. Maybe that's helpful as well.
Great. So a great recommendation would be talk for the family council to talk, and the residence council
Hmm.
to connect with the food services, nutrition folks
Hmm.
to ask about how menus are developed and
Right.
what foods, snacks and beverages and so on made available
Mhm.
that can support bone health.
Exactly, exactly. And there is through one of the websites that I mentioned, Jairus.
Mhm.
There are researchers that are available to go to any facility and to work with people to make sure that they're providing, because there are regulations and expectations that the dietary departments are meant
Mhm.
to be following. So, if we talk about it, I think that's helpful.
And there are folks in the Q&A in the chat who would be very excited to have to you or someone from the team attend to speak at a family council meeting. So
Absolutely.
we'll make sure
Mhm.
that contact information is available in our follow-up materials.
Sure.
So that way folks know how to get in touch with you, Lisa, and
Yeah,
others.
that would be great. That would be great. And I would certainly be happy, depending on where you are in the province. As I said, I cover the Hamilton, Niagara,
Mhm.
this end of but there's somebody that covers all over the province.
Wonderful.
Mhm.
Okay. So, there's folks in the chat, Ottawa is one, so we'll get them in touch with someone in
Mhm.
that area.
Excellent.
Um, so, give another moment for questions to come in. I think we've addressed what folks have asked, but Lisa, any final thoughts or anything that you want to say in wrap up?
No, not that I can think of. It's one of the challenging things with doing virtual presentations is not being able to see people and make sure that you're not sleeping when I'm talking. That's I've had that happen, unfortunately. But yeah, and I see that little heart that just went up. That's great. Thank you very much, and I appreciate your time and your flexibility in being here today. That's awesome.
Wonderful. Well, thanks again, Lisa. This is such an important topic, and we're so pleased that you've been able to share your knowledge with us today to help folks better understand bone health, osteoporosis, and fractures, and how we can support our own health and that of folks living in long-term care.
Great. Thank you very much and enjoy the rest of your day.
Thanks so much.
Thank you very much.
Taeyang, I'll turn it back to you.
Thank you, Sam. So yeah, if anybody has any follow-up questions, please feel free to message me and I will forward it to Lisa. Now I will stop this part of the recording. Amazing. So thank you everyone once again for being present today, for sharing your questions and your ideas and your knowledge with us. We hope that this was a very valuable session for you all. So this is a reminder that the first part of this webinar has been recorded and will be made available on our YouTube channel next week. We will be sending a follow-up email with all the content that we have discussed today. And I also want to plug in, we have our last event of this year, 2024, happening next Tuesday. It's a webinar co-hosted with Dying with Dignity, who will be presenting their new resource, announcing 7 keys to navigating a life-changing diagnosis. Registration is active. I will share the link in the chat. But you can also find it on our website and also in our weekly e-bulletin. So please feel free to attend. It is next Tuesday at noon online and it is free. We would love to see you there. So thank you everyone for your continuous interest in our programming this year, and we look forward to seeing you at our future events. Thank you very much, and everyone have a great day.